Thank you, Sudhir. All right, so very interesting topic. I think all of us are probably very interested in keratoconus, being cornea specialists, and it's thrown up there a lot of different associations with diseases and conditions in keratoconus. And I'd like to spend like an hour on this, but I promise you I won't. But just throwing this up there initially just to remind us all about many of the associations, and then we'll get back into some of these and work through it. So when thinking about the associations with keratoconus, we want to think, are these just associations that are comorbidities? Are they risk factors? There's so many different associations. How are they related? And I think just thinking about rubbing to start with is an interesting one, and thinking, is rubbing a cause of keratoconus? This is something that has been revisited many times. Is it just an association? Is it perhaps a symptom of the disease that patients with keratoconus want to rub their eyes? Or could chronic rubbing in itself be a disease entity, such as a lot of the behavioral diseases that we've been inventing over the last 10 or 15 years? So let's talk about some things that we know. Okay, we know that family history and genetics play a role in keratoconus, that there is increased twin concordance of keratoconus in patients. In the CELEX trial, we did find that family history was present in 14% of the patients in the trial. And that if we look very closely at patients with keratoconus and we look at their family members with tomography, we'll find, and in topography, that 60% of them will have suspicious topography. So why is this important? Well, it's important because you don't want to do LASIK on a patient who has a family member with keratoconus, because we know that they're somehow susceptible and at increased risk. Ethnicity also is important. On the Asian subcontinent with India and Pakistan, there's much higher rates of keratoconus, same as in Saudi Arabia. And if you take a patient from India, and if you look at Indians who live in the UK, they also have a much higher rate of keratoconus than their fellow Brits. So coming back to eye rubbing, there are tons of cases. We could probably talk again for hours about just very interesting cases, case by case, on how eye rubbing has caused keratoconus. There's a couple of them. This is from New Zealand, McMoney's, talking about a patient who was born with punctal agenesis in the right eye and carried a handkerchief around with him, and all day long, about 50 times a day, he estimated he would just kind of wipe the water away from his eye, and then developed keratoconus just in that right eye, purely unilaterally. Patients with Tourette syndrome, they're patients who have their compulsion in Tourette syndrome is that they rub their eye. And there are cases, multiple cases, describing either bilateral keratoconus in these patients or patients who are just rubbing one eye with unilateral keratoconus. In fact, if we look at a lot of the associations of keratoconus, and this was done in a pretty good study here by Bauerzier, they looked at 120 patients with keratoconus and did a case control study looking at a lot of the associations that we know of, including mitral valve prolapse, Marfan's, Down syndrome, rubbing, atopy, age, sex, ethnicity, family history. And they asked, which of these actually fall out in both the univariate and multivariate analysis to be more highly associated with the disease, and we could consider possibly risk factors. And if you looked at the univariate analysis, 3 things fell out, and that was atopy, family history, and eye rubbing. But if you then did a multivariate analysis, only one thing came out, and that one thing was eye rubbing with an odds ratio of about 6.3. So it suggests perhaps there's some commonality between these associations with eye rubbing. And a lot of this, of course, we know about. And so if we look back at that first slide that we put up there, a lot of the initial things we could clump together because they all involve abnormal eye rubbing, either because it's a disorder of itching, it's maybe a congenital disorder where the patient is rubbing for stimulation of light, and or developmental delay where the same thing is happening. Of course, then there's also a subset of patients who have tissue defects who seem to be predisposed to keratoconus. Some of these patients may not be rubbing their eyes. It could just be perhaps a disease that is progressing because of abnormally elastic tissue, patients such as those who have Marfan's and Ehlers-Danlos. And we also see a lot of keratoconus in patients with corneal dystrophy. So I want to move now beyond that, because those are things that we've talked about probably ad nauseum over the last couple of decades, to some other things that have been coming out in reports over the last few years. So these are the 3 things we're going to talk about: sleep apnea, nocturnal pressure, which I think of as nighttime eye rubbing, and floppy lid syndrome. So this was back in 2010. A couple papers came out, and actually in the same volume of Cornea, talking about prevalence of sleep apnea in keratoconus. And as reference, background rates of sleep apnea are less than 5%, depending on how you define sleep apnea. And so in keratoconus patients, the prevalence is much, much higher, up to 50%, so possibly about a tenfold increase over the background rate. And often these patients aren't the same folks who have the thick necks and the risk factors for sleep apnea themselves. We often see sleep apnea in patients with keratoconus who are thin and otherwise healthy appearing. Nocturnal pressure. So usually we think about rubbing and patients actively rubbing during the day, but what happens at night? Well, there may be microtrauma at night from the way that they're sleeping. And if it's their hand or their pillow or something up against their eye, that may be analogous to a rub during the day. And this is a very scientifically researched article here out of the Telegraph website, which talks about different sleep positions and how they may relate to your personality. I'm not sure who's a log versus a soldier here. But the reason I put this up is because I think if you ask keratoconus patients the way they sleep, a lot of them will sleep in this free-faller position, the yearner, or the fetus. And a lot fewer of them will sleep actually as a starfish or a soldier, where they're on their back. Most of them like to have something up against their eye. And if you ask their patients, you'll find this pretty much universally. And if some people aren't aware of how they sleep, so you often get that history from their spouse. So floppy eyelid syndrome. So floppy eyelid syndrome we've known has been associated with sleep apnea, but it also turns out to be even more highly associated with keratoconus. And in a case control study looking at this, keratoconus came out to be an odds ratio of almost 20, and if you looked at unilateral cases of keratoconus, that was 35. So clearly an association between floppy eyelid and keratoconus. And this is a patient of mine. Every patient who comes in who I'm worried about keratoconus or has keratoconus, I always pull on their eyelids to check how floppy they are. They don't always avert like the classic floppy eyelid patient, but they usually are very, very loose. And it's often such that the eye that they're rubbing more has worse disease is the looser eyelid. But what I want to show you is not just how easy it is to pull up their eyelid, it's looking at some of the eyelash changes. So if you look at the eyelashes, which you always really should do, I think, for patients who have keratoconus or you're worried about keratoconus or considering refractive surgery even, the normal shape of the upper eyelash is that they curve upwards, and they're usually pretty uniform going across. And you can see here on this patient in their left eye that they're all generally curving the same direction, although there's some misdirection of the lashes. You compare that to the right side, and you see that these are curved back further. Some of them are directed downwards, and there's a lot of disorganization and misdirection of the eyelashes. And you can see a little bit, I think, in the picture, but you can, if anyone had to guess which eye has worse keratoconus, it's the eye that has the lash misdirection. And so why is this happening? I call this the Carlson sign when I see it from my preceptor in fellowship, which is Alan Carlson, because he actually would scare the patients. They thought he was psychic because he would look at their eyelashes before doing anything else, looking at their vision or looking at their history, and start telling them how they sleep at night, which side they sleep on, which eye is not seeing as well. And 9 out of 10 times he would be right, and the patient would be like, "What, are you watching me at home?" And it's actually astonishing. And I started doing it in my own practice, and I scare myself because if you look at these eyelashes, that pretty well correlates with patients sleeping against the eyelash at night, which makes sense. And that nocturnal pressure seems to play a role in the progression of keratoconus. It's something definitely to look out for. So in terms of the behavioral patterns of patients to look out for, we talked a bit about sleep patterns and also how this may play into the laterality of disease. One thing that we should mention about sleep patterns is how sleep apnea is involved in that. So patients who have sleep apnea don't like to sleep on their backs. They don't like to sleep on their backs because their soft palate drops down and they become apneic during those periods. So those patients are more likely to sleep on their side or on their face unless they have a CPAP machine. So not uncommonly, I'll see patients who've gotten sleep testing and then start the CPAP, flip onto their back, and their disease suddenly stops progressing. So just be aware, though, that may be a relation between the three things, keratoconus and sleep apnea, and also then floppy lids as well, which may be partly from not just rubbing, but that nocturnal pressure on the eyelid. One thing that also has been interestingly described over the last few years has been the rubbing patterns of keratoconus versus blepharitis versus allergic rub. So I always like to ask patients how they rub their eyes and have them demonstrate it for me. Typical allergic rub is something where the patients are rubbing with their finger in the corners of the eye, whereas we know with keratoconus patients, they often take their palm, their knuckles, and they get in there and they push up against the globe of the eye. And when you see it, you're kind of, please stop. Versus blepharitis, where they're often kind of, if they're pushing against their eye, they're mostly focused on the eyelashes. So I always like to have patients describe for me that rubbing pattern. So how do we tie this all together? Well, the theory that a lot of folks have for those patients who are in this subset where they may be progressing because of microtrauma is that in spite of how keratoconus has been described for all these years as a non-inflammatory disease, for many folks there probably are inflammatory mediators involved, and those inflammatory mediators in theory would be from the microtrauma causing some release of mediators that are then leading to keratocyte apoptosis and then the breakdown of tissue, softening, and corneal thinning. So there's a lot more to prove and to think about here, but just a few things that we can consider in our patients these days. So thank you.